So I want to welcome you all to this important and very topical webinar that we're putting on, Collaboration During COVID-19, Healthcare Coalitions and Regional Assistance Committees. And the purpose of this is we're trying to look at how health systems and hospitals organize themselves in regard to responding to these events, to disasters events, any disaster events, but in this case, particularly COVID. And I think there's been tremendous lessons learned in this unfortunate and unique outbreak. And so we've brought together some leaders in both the healthcare operations side, but also kind of in the academic side to discuss this important topic. And let me introduce them to you briefly. The first is myself. I'm the director of the National Center for Disaster Medicine and Public Health. We're a interagency center that's located at the DoD, but work across the agencies for disaster preparedness and response. The second is David Miller. He's the executive director for the Emergency Preparedness and Response, the New York City Department of Health. The third is Eric Epley. He's the executive director of the Southwest Texas Regional Advisory Committee, or the STRAC, as they say. And our final speaker is Dr. Diane Barnett, Associate Professor, Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. Next slide, please. We have to give our designation statement and the fact that we do have CMEs available for this website. So should you have any questions, you can reach out to the organizers to clarify that. Next slide, please. We have no disclosures across the board. We don't have any disaster stocks, or we're not invested in disasters or COVID. So I think we're good there. Next slide, please. Briefly, just about the National Center. National Center's been around for a decade now. We were stood up by a presidential directive 10 years ago as an interagency center that's focused on disaster health and public health issues, particularly education and research. We've conducted webinars over the course of those years, and of course have recently begun increasingly focused on both COVID, but also healthcare system preparedness issues. We have a new large grant that's looking at improvements in the national disaster medical system and better ways for that system to organize itself for any catastrophic event, whether that's a large earthquake or another infectious disease event or an overseas conflict. And so this webinar is part of that research study and is a way of discussing that topic and its importance. So with that, I'd like to ask anyone listening in to mute their mics, and we'll turn to David Miller to give his initial presentation about how the New York City health system responded to this event.
Good afternoon, everyone, and thank you so much for having me. I serve as the Executive Director of Healthcare System Readiness in the Office of Emergency Preparedness and Response at New York City Health Department. And for our COVID-19 ICS activation, I serve as one of the branch directors for Healthcare System Support Branch, as well as a special advisor for healthcare systems, and focusing on alternate care sites, vaccine hubs, as well as just general healthcare support. I'm going to today just describe the New York City Healthcare Coalition and then give some highlights for our COVID-19 activations. The New York City Healthcare Coalition is a collaboration of both healthcare and non-healthcare partners organized to support healthcare system preparedness and response for all hazard types of emergencies, mass casualty, catastrophic public health events, much like COVID-19. The shared mission of the New York City Healthcare Coalition and its members is described as promoting and supporting all hazards preparedness throughout the emergency management cycle and providing situational awareness, information sharing, and any type of support through shared resources, training, and anything else that can be pushed to the New York City's complex and diverse health system. The goal is to serve and protect New Yorkers before, after, and during an emergency that impacts healthcare systems. As a recipient of HHS ASPR's Healthcare Preparedness Program, which is a federal grant for public health emergency management, New York City Health Department leads the efforts of the New York City Healthcare Coalition. And this is where I would posit that the New York City Healthcare Coalition's authority is quite diffuse. The New York State Department of Health, CMS, Joint Commission, and others actually regulate and accredit the healthcare facilities within New York City jurisdiction, and New York City Emergency Management, that agency department is charged with ESF8, Emergency Support Function 8 coordination. But I would suggest that the Healthcare Coalition in New York City is highly influential around public health emergency management. And I think that the best way to describe the Healthcare Coalition in New York City is a coalition of coalitions. I'll tell you why. So we collaborate with 55 acute care hospitals, 168 nursing homes, 78 adult care facilities, 139 outpatient dialysis centers, and 44 FQHCs that represent more than 100 facilities. There's also more than 700 health home care agencies. And all the affairs of the collaboration that is focused on the Healthcare Coalition is overseen by our governance board. One of the roles is to provide high-level oversight and guidance in setting programmatic goals for the coalition and for the HPP program, and try to help us navigate the policy challenges experienced by the city's healthcare system during sorry, I was muted. The New York City Healthcare Coalition Governance Board is comprised of representation from FDNY, the Fire Department of New York, and its Division of Emergency Medical Services, the City Health Department, the Hospital Association, of which all of our hospitals are members of, and New York City Health and Hospital, which is the municipal hospital system composed of 11 acute care hospitals, as well as those elected from each of our healthcare sector domains. This would be from our coalition of coalitions, the Borough Coalitions, the Network Coalitions, the Independent Hospitals, Primary Care, Pediatric Disaster Coalitions. The governance board often works on programs and plans that address citywide planning priorities and also give us strategic direction for resource allocation during health and medical crisis. When necessary, the governance board, as in the case of COVID-19, comes to support directly the city response. A large body composed of all the HPP subrecipients forms the Leadership Council of the coalition, and it meets regularly to represent each of the sectors in the coalition. The Leadership Council engages healthcare leadership through its operational decision-making capacity and transmits important information from the coalition back to executive leadership at each of the institutions, such as the hospitals and the nursing homes, as well as up through that governance board that I mentioned earlier. All New York City healthcare providers and non-healthcare providers partnered in emergency management and response activities are considered the general membership of our coalition. So we have a number of sub-coalitions, if you will, and it's easy to describe just the couple of types. First, we have borough coalitions. These coalitions are geographically based in the 5 boroughs of New York City. Boroughs is another way of saying counties in New York City, and they help coordinate training and exercise and sometimes response. They're all very different and have specialized over the years. And so some of them have focused on whole of community preparation response. Others exercises specific to things like burn bed capacity in remote boroughs or outer boroughs, mental health, and also driving citywide situational awareness. Most of them are run by hospital networks, and one is actually led by one of the borough president's offices. We also have sub-coalitions called subject matter expert sub-coalitions and the trade associations. The trade associations and the SMEs help other sub-coalitions and provide information specific in a variety of ways, specific to their specialty or their facility provider type. The SME coalitions, they include primary care that is currently focused on FQHCs. All of our nursing homes associations are represented as well, the hospital association. Then we also have our pediatric disaster coalition and another one focused specifically on dialysis outpatient centers. We've broken up the hospitals into independent hospitals, the municipal hospital system, and the network coalitions. The network coalitions are just that. They're the hospitals that are belong to larger networks, and it's defined by their central delivery of services to include interdisciplinary healthcare services, and usually coordinated by like a central department of emergency management. And we integrate them in the HPP program in a specific way currently to develop and sustain capacity building in each of the hospital networks. Again, and they oversee a number of different healthcare facility types as these networks are tending to grow larger and larger. And then a special note about our integration with Emergency Support Function 8. Under the New York City Charter, New York City Emergency Management manages the EOC and its support functions. And when activated, ESF8 help coordinate all the resource requests through the health and medical agencies, as well as provide conduits for information sharing. So a couple of things that happened in the years prior to the COVID response, I think were remarkable and helpful in preparing New York City for its response to COVID-19. One is the Secret Shopper program. And this was developed in hospitals for highly infectious disease training and utilizing guidance from the New York City Health Department and in collaboration with all the hospitals, we did mystery patient drills that focused on the screening and isolation protocols and staff level readiness for an infectious disease outbreak. The one that we conducted just before the COVID outbreak, we had the massive majority of hospitals notify nursing, notify when a patient that was suspected of MERS come in, but we also saw gaps in PPE. And so remediation of those gaps was really important, I think, for COVID response. And then we had implementation of projects conducted to exercise mass casualty incident response, and all hospitals had completed in the last budget period a self-assessment of mental health plans. Then just a few years ago, HPP had focused deliverables on mass fatality management planning, in which each hospital developed or redeveloped their mass fatality plans, and supported directly by the Office of Chief Medical Examiner in New York City. Those plans included logistical planning for body collection points, which would be a big mainstay of our patient surge and fatality management in the COVID-19 response. The coalition itself really focused on information sharing and guidance sharing throughout the coalition, as well as surge patient management, again, in kind of a diffuse way. The health department supported PPE from the Strategic National Stockpile, and New York City Emergency Management with the health department also supported staff, helping with staff shortages. Both municipal entities and hospitals ran alternate care sites, and now we've been really focused on the equitable distribution of vaccine. The health department in New York City, we activated on January 30th, and for COVID-19. And as community spread became apparent, we saw that all the adult negative pressure isolation rooms were filling up quickly, and that we were going to have this patient surge. Tents were erected outside of nearly every ED, and we tried to push around guidance about how to use those tents effectively and safely. But really by March 18th, 4 of the city's largest healthcare systems had canceled elective surgeries, and we knew that there was a critical increase in a need for critical care beds and med-surg beds. So the health department, in kind of collaboration with different parts of the coalition, developed a public health and medical operations group to support alternate care sites and surge patient movement. And we also developed a specific facility liaison program that was geared up. We took what would have been out of work school nurses as a school shutdown, and we made them liaisons to each of the facilities, specifically hospitals and nursing homes. Hospitals thought this was kind of redundant. They kind of have a direct line to each of the Office of Emergency Preparedness staff, but nursing homes really never had that connectivity before, and so we were able to push out a lot of FAQs about common guidance issues, PPE testing, in a really very complicated and very confusing world that we lived in for those couple of months. A lot of our response also focused on information sharing, and it's, I think, been about a decade since have bed programs that that no longer exist in New York were sharing census information, and we were able to expand the use of our situational awareness tools, namely Giovanni through our hospital system, to focus on what census looked like in alternate care sites. And this actually ended up being a springboard for a lot of discussion about how we can do real-time census sharing. And that pilot now has resulted in all the hospitals being offered opportunity to share in real time their census. So a lot of this was kind of the fruitful outcomes of coalition activities that started in committees, talked about what we wanted to do, but really having a real world application. The governance board met a lot and started integrating with the ESFA calls that we had twice a week and then daily during the heights of our COVID waves. And even as the waves rescinded, governance board shared a lot of practical situational awareness information about what was going on in healthcare facilities that we were able to push up through different ICS structures to really inform decision makers about what was going on the ground in each of the facility. They gave us really important feedback on PPE, push outs from the strategic national stockpile and ventilator supplies and management. And even our borough coalitions, when they met to support our leadership council, was able to share information on staff training, such as how to prepare, how different networks prepared nurses to go from med surge to ICU level nurses. The alternate care sites, and you might remember from the news the work at the Jacob Javits Convention Center and the U.S. Naval ship Comfort. There was a lot of integration with NDMS and U.S. Public Health Service. And you might also remember that they opened as non-COVID sites. And it was really strategically important that as the Comfort ship arrived on the 30th of March and the Army Field Hospitals and Public Health Service deployed on the 27th of March, they were considered non-COVID. And it really took the coalition with the help of the Hospital Association to have a all-hands leadership meeting to push for the change from the White House directive down, from changing from COVID to non-COVID. I just want to point on the future of the coalition's involvement and risk reduction. HPP this last budget or this current budget period is helping hospitals and supporting hospitals to look at their risk assessments and gaps during the last couple of waves of COVID here in New York City and assessing their key findings and their gaps. Also, DOH-MH has been supporting throughout the coalition technical assistance for long-term care, which I'm sure you've heard a lot about in the news as well, supporting staffing shortages and infection control through a number of technical assistance programs. So that concludes some of my highlights in the coalition. I think I want to hand it off to Eric to talk about track.
Thanks, David, and thanks, Dr. Kirsch. Oh, sorry, you want to do an introduction or you want to just take off?
Can you hear me?
Yeah, can you hear me?
So I just wanted to say, you know, David pointed out the complexity of organizing not just hospitals and healthcare systems, but the entire public health response to such a disaster. And I'm turning now to Eric to give us all the answers. Go ahead.
That's dangerous. Thank you, Dr. Kirsch, for the opportunity. And it's a pleasure to be on the panel with Dan and David. Great group of guys. My name's Eric Epley. I was paramedic for 32 years. I was a police officer for 13 years. I'm a certified emergency manager. I'm currently the executive director and CEO here at our organization at STRAC. That's our acronym, but it's a mouthful the other way. I've been involved in the RAC. I was a flight paramedic at San Antonio Air Life in the 90s and became involved in regional trauma and emergency healthcare system development in the late 90s, 98, and then went full-time in 2000. I've been here ever since. Our organization started initially with about $12,000. They handed me a checkbook and last year's annual revenue, which is mainly grant dollars that are passed through, was about 24 million. We have 63 hospitals, 71 EMS agencies, 18 helicopter bases, 26,000 square miles. So San Antonio is the kind of the hub, but the spoke around us in this regional advisory council area is about 26,000 square miles, about the size of West Virginia. and if the next census will come up, it should be about 3 million. It's about 2.8. We have 72 long-term care, 74 dialysis. I mean, a partridge in a pear tree. It's the 7th largest city in the country. So it's a big place, but it's also a very rural and frontier place. It's not hard to drive 50, 60 miles and be, where there's more goats than people. That can happen pretty quickly. And we have 3 counties that are officially designated as frontier, which means they have less than 5 people per square mile. So providing, daily healthcare in that circumstance and the hub and spoke model is, of course, a challenge, but one that we welcome. And I think we do pretty well with our regional trauma and emergency healthcare system. I'm going to speak quickly about RACs. Regional Advisory Councils were formed in 1987 with some legislation in the Texas legislature. The Omnibus Rural Healthcare Rescue Act created the Texas trauma system with 2 goals: that no one would ever be injured in Texas ever again. But if they were injured, that they would have the best possible care no matter where they were in the state. To that end, the short elevator speech from my organization is we're in charge, we're to develop, implement, and maintain the regional trauma and emergency healthcare system, which means we're involved directly with daily healthcare. Today on my plate, dealing with better utilization of our freestanding emergency departments by EMS, some cardiac designation issues for some of our PCI centers, and EMS wall times. So that's sort of like my day job before we get to the disaster stuff, which we've also embraced since, in a big way, since 2000 after September 11th. There are 22 regional advisory councils in Texas. I am one of those 22. San Antonio has taken a lead, I think, in the RAC system, obviously, but you should know that all the RACs are generally structured the same way. We are in legislation, kind of quasi-governmental, but we are independent 501c3 organizations, and our board of directors is made up of the providers from that area. So I have hospital administrators, surgeons, emergency medicine physicians, nurse managers, fire chiefs, EMS directors, et cetera, that are on our board. And every healthcare system, I have HCA, Christus, Tenet, UHS, CHS, all the initials within the corporate healthcare structure. So I'm well versed in, the competitive environment, the highly competitive environment. But we have practiced here a word I call co-opetition, which, if you work together for certain things, you can be competitive, for regular stuff, but on game day with disaster and other things, we can work together and have, a really good working relationship. And that's proven out throughout COVID. We have a 24/7 our MedCom Communications Center manages all critical trauma transfers. So if you're in a car wreck in Uvalde, Texas, which is 90 miles to the west, they pick up the phone, they call MedCom, and that trauma transfer is routed to one of our 2 level 1 trauma centers. We're blessed in San Antonio to have a civilian military partnership with the Brooke Army Medical Center that's on the San Antonio military medical system on Fort Sam Houston. And we have 2 level 1 trauma centers. The military trauma center takes civilian patients every single day. And they're fully integrated into our regional trauma system. Let me just jump to our makeup at our EOC. So as opposed to the way David kind of described it, we have a regional medical operations center that is a part of the EOC. At our EOC, we're kind of a blend between ESFs and ICS. So frankly, we kind of follow an ICS model a little bit better than we do the ESFs. But our emergency support function 8, health and medical, is assigned to the regional medical operations center, which is a branch of the operations section. So as the RMOC director, I attend all command meetings, and I'm in all emergency operations center activations and discussions with leadership, city management, county management, et cetera. That facility, the RMOC, is about a 60 by 60 room embedded. It's on the floor of the EOC, and we will have a hospital rep from each of the major systems show up physically for the entire time we're activated. And we'll have public health, obviously, from the city, and then from our regional health, and then also EMS and the air medical agencies, et cetera. So we'll have 40, 50 people in there, which is super helpful during our main uses for the RMOC is during hurricane season, right? We probably have had more RMOC activations for hurricanes. And at least for Ike, Rita, Ike, and Harvey, we moved about 2,000 inter-facility transfers from the coast of Texas up to San Antonio. That's just to San Antonio. We moved more than that, but that's what we had to absorb. And so this idea of load balancing and moving patients from hospital to hospital, I'm proud to say in each of those hurricanes, we never canceled an elective caseload, an elective case during those hurricanes, because we've learned how to load balance really, really well. During COVID, we're on day, for us, it's day 411, really. We started on February 7th when we'd been having meetings and talking and that kind of stuff, but the planes, we were lucky enough to receive some of the cruise ship folks from Wuhan directly on the 747s that you saw land at Joint Base San Antonio, Lackland. And those people were housed, and we were integral to the relationship between HHS, the DoD, and Department of State and other federal agencies, along with our state health department, our state emergency management structure, and of course the city and county government as we ramped up. A curveball we got was that anybody who had any sign or symptom was immediately whisked off the base and taken to a local hospital. I hadn't checked the definition of quarantine and sort of how to manage patients in an infectious disease, but it seemed like we ought to just leave them there until they got really sick. But that was the rules of the road that were laid out between the federal agencies. And so we ended up putting COVID into our hospitals with people that really didn't even need to be admitted, which became a financial problem later on as well. For COVID activities, I'm not going to go all the things David said. We basically did almost all of those and more. We had a responsibility. We had twice daily calls. We have a group called the Med Leads. I have all the CMOs and CNOs on a medical leads. I have a CEO group that I talk to regularly as well, but really for where the rubber meets the road about what we're actually doing in the hospitals, the CMOs and CNOs, and I have a thread, I have a text thread that has been going on forever. And we had daily and sometimes twice daily calls with that to organize. We also had infectious disease leads, an ID leads work group, and that was 2 or 3 infectious disease physicians from each of the major healthcare systems. And so we had a consensus-based approach to how to, when to start doing visitor policies, about to ramp down on visitors. So all the healthcare systems did that at the same time. But all the practices we did throughout the operation, whether we were sharing on high flow units, that all ran through the RMOC. So if a hospital needed 10 more high flow units, they call the RMOC. Their rep says we need 10 high flow units. We go, well, we got 5, we'll give you 5. Or if we're having to distribute those, we'll take the load every day and sort of distribute those with equipment. We also had to set up an entire PPE operation with the State Operations Center. So at our hangar, we have a hangar that houses our 18-wheelers and the other response equipment we have. So we kind of had to empty that out and establish a distribution, a pod for PPE, not only for hospitals and EMS, but eventually for dentist's office and private practice. Sort of anything medical PPE went through us. And we literally filled a 40,000-foot hangar with PPE, and about, at the peak, about 10 to 12 people on duty every day with a flow process for that. Well, of course, we did data collection with HHS Protect and all the things that I'm sure the people on this call all know about. We established on March 13th the first drive-through. I don't know if it's in the nation, but certainly in Texas, we created that kind of on the fly. The governor announced it that afternoon, and we moved it to our Coliseum location, which was indoors, which was frankly much better. And then eventually trained all 1,200 Texas military National Guardsmen to go do mobile testing across the state. So that training effort all came through our HCC, through the STRAC RMOC. We developed that training curriculum, obviously. Doing load balancing with patients, I want to talk about that in a little bit, PPE distribution. And we have contract nurses, obviously, that are being organized by the state. They're basically assigned to us. So they'll cut us 250 nurses, and we have to distribute them or respiratory therapists, whatever, and put those into the right places. At our peak in January, we had about 1,650 extra staff that one of my team leads was managing basically daily, to include all the challenges of running your own nursing agency, essentially, with bad behavior, all kinds of problems, but also some really good effort that we were able to supplement with the military, with the UAMTFs and other efforts from the feds. I guess that's about it. I'm going to pause there. I am going to talk some about load balancing. I know our Regional Medical Operations Center in San Antonio, all the major locations in Texas, when El Paso was kind of going under in November, we established a load balancing, and we moved a little over 300 patients across Texas to Dallas, Houston, San Antonio, Austin, Tyler, all through this network of RMOCs, talking to RMOCs. And so when they were overwhelmed, they had a physical bed problem. We got close, but we never really had a physical bed problem. We had a staffing problem, right? So when we're out of beds, we just need more nurses, and magically we have beds. We open up another wing, but per capita, El Paso is about half of our physical capacity we have in San Antonio. So they literally ran out of beds. And so moving those critical patients to a hospital that was, able to deal with them pretty effectively was the smartest thing. Although it's a little bit like a hurricane in El Paso, right? We're moving a bunch of interfacility transfers. And I think our experience with hurricanes made this seem not so bizarre, because we talked to other people around the country and they're like, you move 300 ICU patients around to other parts of the state in planes? So it's a little far-fetched, but I think it's actually replicable and pretty easy to do. It's not hard to do. So anyway, I'll pause there. That was my 10 minutes. So I'll turn it back over to you, Dr. Kirsch.
That was great. The functional response organization that the RACs do, I think, is very impressive. And I thank you for the summary of some of the specific activities. So let's move on to Dr. Barnett. He recently published a piece on HPP roles, because we're talking about kind of different models here, going beyond HPPs to RACs to other organizational systems for healthcare systems to respond. So Dr. Barnett, if you could give us a little summary.
Thanks, Dr. Kirsch, and thanks very much for having me today. So what I'd like to do is describe some key points from a concept paper that Dr. Kirsch and colleagues and I recently published in the Journal Disaster Medicine and Public Health Preparedness. And the title of the paper was Reexamining Healthcare Coalitions in Light of COVID-19. For this paper, what we did is we conducted a strength, weakness, opportunity, and threat analysis, looking specifically at healthcare coalitions at a macro level, and how COVID-19 might catalyze changes and improvements just in a systematic way for healthcare coalitions. It's sort of a rising tide lifts all boats kind of a framework. So I'll be interested in people's feedback about these ideas, but I thought I would just summarize these here briefly. What we wanted to identify through this paper was how can we learn from insights from COVID-19, specifically shortcomings that occurred that have been highlighted in the peer-reviewed literature, such as hospital surge management, issues relating to supply and distribution of PPE and other critical supplies, infection control practices, operational collaboration across the healthcare community, and data sharing platforms. And all these roles are ones that HCC's, healthcare coalitions writ large, were designed to take on. So this could be a potential, if you will, silver lining in terms of opportunities for innovation. So just very briefly, we looked at healthcare coalitions, again, writ large, and found that some of the strengths in this, against this backdrop, include the fact that healthcare coalitions in many ways are more than the sum of their respective parts. So that's a in terms of a synergistic framework, that really is a benefit of healthcare coalitions. They also, as you're aware, well, many of you, if not all of you, are aware, promote enhanced interoperability among the constituent organizations within HCCs. They allow for sharing of resources and information and improving communication among the constituent agencies and the public. There are also forums or basically entities, HCCs are, that can facilitate coordination among a variety of core members. And this, by the way, can be broadened from their current constituents. Currently, they include hospitals, public health agencies, EMS, and emergency management, but also can, and in some cases do already, but can even continue to expand to include behavioral health services, post-acute care facilities, medical device manufacturers, and so on. So those are strengths that we identified. Weaknesses with regard to COVID-19 and healthcare coalitions included one of the administrative aspects of HCCs right now, which is that, as you're aware, HPP funds and HPP funds fund healthcare coalitions are administered currently by state and territorial health departments, which have little influence really on the delivery of care or the allocation of the healthcare resources during a disaster. And these state and territorial agencies can't really compel healthcare organizations to participate in healthcare coalitions. Furthermore, and I speak as someone with a background, I used to work at a large urban health department prior to beginning my academic career. And many healthcare coalitions are coordinated by chronically underfunded health departments. That's not news. And so when health departments are already being forced to do more with less, fewer resources, that compounds the administrative challenge for healthcare coalitions. Sometimes we found in our analysis, healthcare coalitions and their membership often may have differing response missions and frankly, differing degrees of meaningful participation. And again, this is a 50,000 foot level. This is not a critique of any one healthcare coalition whatsoever. And as we've heard from David and Eric, there's been extraordinary work. The last item in terms of macro weakness is that obviously pandemics don't observe state geographic boundaries, and the current sort of geographic framework of healthcare coalitions are state-based and local-based health departments. So there are these sort of artificial boundaries that may not be helpful in terms of responding to current or future pandemics. Opportunities. You may be aware that actually pre-COVID-19, ASPR had begun an initiative to create a national disaster healthcare system that really had nothing to do, it was actually pre-COVID. And COVID may in fact serve as an accelerant, if you will, to incorporating healthcare coalitions in a meaningful way toward that end. And also, it could result in better alignment across health, HPP, PHEP, and Homeland Security grant program requirements. And there is currently some disjunction among those requirements. There are opportunities we've also found through our analysis for sustainable funding mechanisms. As you're aware, a lot of funding in disaster response is sort of post hoc. There's an event and then there's a funding stream subsequent to it. And that creates challenges in terms of sustainability, which is one of the threats that I'll talk about in a moment. But there may be alternative funding mechanisms that are not solely reliant on federal sources. And then last but not least, with threats, as I alluded to, event-specific infusions of federal funds after the fact don't necessarily promote sustainability. And also, healthcare coalitions tend to rely on annual and variable congressional appropriations, and that really poses a challenge in terms of enduring optimal functioning of healthcare coalitions. So based on these strengths, weaknesses, opportunities, and threats, we came up with a series of 4 recommendations, again, macro level, but we think that these may be helpful for consideration. The first is that right now, there really is not a rigorous across-the-board evaluation of healthcare coalitions and their degree of participation, and even, frankly, accountability aspects. And that presents an opportunity, frankly, for such a system to allow for benchmarking of current HCC functioning as a baseline for continuous quality improvement, which as I'm speaking to the choir is a critical aspect of disaster response generally, continuous quality improvement. The other item that we thought along those lines is that healthcare coalitions could be more explicitly embedded into incident command system components such as medical operation coordination cells within sub-state, regional, and statewide EOCs. Another second recommendation, very briefly, was to reconsider frameworks for administering healthcare coalitions. And one, because of the challenge with regard to state and local health department management, as I mentioned earlier, there may be alternative routes for administration. These could include, for example, identifying or creating nonprofit organizations within states to administer HPP funds, or even directing funds to an entity like a hospital association, where there may be a high level of established engagement. Third, very briefly, creating more incentives for more meaningful hospital and healthcare leadership, healthcare system leadership in healthcare coalitions. This can be done, we propose, by a variety of possible mechanisms, including Medicare reimbursement adjustments that reflect the level of contribution of healthcare systems to healthcare coalition activities, and even things like providing tax incentives or insurance benefits for increased private sector investments. And last but not least, coming full circle, I had alluded to the next generation discussion that was pre-COVID at ASPR regarding national disaster healthcare system. And frankly, these insights from COVID and as they relate to healthcare coalitions can help to further potentially catalyze that initiative and really put healthcare coalitions in a position where they can be at the vanguard of improvement in or even development of this national system. And this includes not just partnerships, but even infrastructure things that we've identified that are critical to COVID-19 response that healthcare coalitions can play a more explicit role in, including things like telehealth, surge capacity dashboards, immunization registries, and the like. So that's just a brief summary, again, a sort of a macro level of items that we identified as areas for improvement, enhancement, and SWOT analysis based on our analysis. Thanks so much.
So this all comes about not just from COVID, but during the last administration, the Assistant Secretary for Preparedness Response had done a lot of work in describing what they called the 21st century NDMS, National Disaster Medical System, with the movement towards empowering health systems to manage their own responses. And that's a conversation that's ongoing and is part of the work that the National Center is doing now. But there's a couple questions for the audiences along that line, and I'll pose both of them to the group, and let's take the first one first. And one is, and I think Dan alluded to this, can healthcare coalitions play a role in actively managing hospital and health system response? So that's phase one. And the second one that's come up repeatedly here is, how then do we fund these activities? The Texas STRAC, Eric pointed out, had a budget of $24 million, which is way more than the HPP funds that flow to individual healthcare coalitions. So how then do we fund these things? And let's start back at the beginning and turn to David for both of those questions.
Sure, I think this is a very challenging question because coalitions are situated in different places in different spaces. And so, in Eric's model, you have either 501c3 or some type of a kind of a neutral party brokering deals. And that's kind of a safe space for healthcare entities that are engaged in competition. I think even more categorically as we certainly in the Northeast move to larger and larger networks. So can coalitions play roles in the response? Absolutely. But they need to be open to brokering the deals and navigating the political waters of what that response looks like specific to healthcare. So I think it's going to be different in different regions, and I think that's why you've seen so much diversity among the coalitions in their capability for response in COVID-19. As I said in my presentation, specifically, I think our power is influential, and it's influential through the HPP deliverables. And I'll take an opportunity to kind of answer another question was, I think it was specific to how can you get people to encourage coalitions to work together. Well, we kind of use even the small dollar amounts we have in HPP to design deliverables that that ask each of the subrecipients to coordinate with us, whether they join a subcommittee to work on mass casualty, or we're asking them to put in their contact information. Each of these can be opportunities to coalesce response activities in a significant way if it's done right. But I think it requires some strategic planning.
Eric, do you want to comment?
Yeah. I mean, I'm biased. I mean, I'm clearly biased about what I'm about to say, but I think that having not the health department, it's better in a model. And when the way we're doing it is we're kind of like, if you break down and you pull over to the side of the road and a fire truck pulls up behind you and the guys are getting down, you're like, oh, they're here to help me. That's so great. But if you break down in the same spot and a policeman pulls up and gets out with the dark glasses on and with the lights on, you go, he's probably here to help me. But the first thing you do is look at your inspection sticker, right? And it's like that we have to recognize there is even though sometimes there's different divisions, at least in Texas, our state health department is also the regulatory body for EMTALA violations and for all other kinds of things. So the we're here to help doesn't necessarily, it's like the state trooper walking up and saying, I'm here to help you change your tire. You're like, well, don't look at the 2 pounds of pot I have in my back seat, please, officer. So I think if you have a generator that doesn't work, you don't really want that regulatory body coming to help you with as you prepare to try to, do things. I think the sum of all the different parts is what makes us valuable and makes it easier for the disaster and health care to work well, is that we do everything day to day with the emergency department nurse managers and with the VPs over emergency services and all the other people who really in this crisis are the ones I've worked with. To be fair, our preparedness teams in the hospital, the people who are hired to do so it's so funny. We even have words that a lot of people, we have to live both worlds. The EOC to me means the Emergency Operations Center. But if you tell that to a hospital person, they say, you mean the Environment of Care chapter of the Joint Commission? So we have EOC people who work in the hospital that are making sure there's a lot of check boxes in that thing. That's a full-time job. Those people don't routinely, at least in our experience, they really are not as clinically sophisticated. Sometimes you're lucky enough to get somebody who's a nurse, but a lot of times they can be kind of professional emergency management types that went to, a 4-year degree and got an emergency management, and they've drifted into healthcare, but they're not clinical. They don't really know how the hospital truly works. They know how the power stays on. They know how to hook up to the water. They're doing all the stuff that's in their job. But on game day, they're not running the disaster like you would think. And so the linkages that I have to live in the RMOC is with what I call the real clinical part of the hospital. And then the part that we got to make sure it keeps the hospital up and running. So the other part works, right? They're two different parts of the hospital's brain, if you will. The people who are trying to keep it up say, don't bring more patients. What are you doing? We can't keep the patients. We're here with the power on or whatever. We kind of just lived through a winter storm. By the way, we have no idea how to, if there's a quarter of an inch of ice, it's all over. So that's what I would say on the structure thing. I mean, I think loosely, I've talked to Melissa Harvey about this a bunch. I think there's about a third of them are in hospital associations, a third in public health, and a third are in kind of what we do with the regional trauma and emergency healthcare systems. I think those are the numbers, if I remember correctly, from back in the day. And Admiral Vanderwagen, who I think was either the first or second ASPR. We had a listening session in Baltimore at UPMC, I think. Is that right? Does that sound like so we met there and went through, and they had Miami and Seattle, King County, and me and somebody from Cincinnati. There was like 7 of us, and they built the next set of out of that listening session, they built the next set of requirements. And it became much more about regional collaboration and that kind of stuff, because I think they'd seen those successes. So it's not so much about buying stuff as it is organizing. And to David's point, if we could just spend, I don't know that there's going to be one size fits all. Okay. So first of all, I'm a big proponent of the regional trauma and emergency healthcare system, that disaster response is the regional trauma and emergency healthcare system squared, even cubed. That's what I think. new partners, new capabilities, but it's that day-to-day interaction seems to be a really good base of operations because it's operational. It's actually taking care of patients every day. I have meetings here all the time with the EMS chief and the medical director and the hospital nurse managers and whatever. But you can't jam one size fits all into everybody, I don't think. And so I think if we just did a better job with the people who actually do the work, building the targets for what we're trying to get done, the objectives, and then measure us on it in a meaningful way. Because if you did that, I think you would have a better outcome. You'd have a more structured, doesn't really matter what the entity is that's doing it, as long as they have the same goal in mind. And the goals have been kind of all over the place in the 15 years I've been dealing with this program.
Right. So Dan, any thoughts along those lines from the opportunities and recommendations?
Absolutely. So those are really very all on point comments, I think, by David and Eric. And I agree that one size fits all is not necessarily the approach that will work for each jurisdiction. Obviously, there are different hazard vulnerabilities and things like that. I think there could be perhaps some modifications, though, just systemically, especially building on this recent initiative to create this national level sort of second generation hospital preparedness program or hospital or healthcare response program through ASPR. I think there could be some just even baseline standardization components that even the allowing for regional variabilities could be so relevant to all jurisdictions that it could lift all boats. Just my 2 cents, but I think the points from David and Eric are extremely.
I also think there've been one last comment because he made me think about it when he kind of got lost on the initials. I mean, I think that's part of the problem. Is we have the National Disaster Medical System, we have FACEP, we have HPP, we have MMRS, which I've almost forgotten about. I mean, it's like we have all of these systems, and they've been built asynchronously and not really with the same strategy. Honestly, I mean, the very fact it's called the National Disaster Medical System, and it's really the National Hospital Transfer System, and occasionally send a team system. I mean, that's exactly. Like I don't know why all of that isn't. I'm not saying NDMS is the home for all this, but I'm saying it seems like you would have a strategy and the USAR system and FEMA is a kind of microcosm of what I'm talking about. Is those teams are all in different locations, different departments, but the USAR framework works pretty well, and everybody knows what it does and knows how it fits in. And so we've built our emergency medical task force system in Texas with 8 teams across the state in a very much sort of copycatting the USAR system, and for the response capability with ambuses and with ambulances and field hospitals and such, that's been super effective for us because there was a strategy. We just called it the Texas Disaster Medical System instead of the National Disaster Medical System. And that entire bubble is how we've been able to organize things.
Yeah, and that's a key point. So speaking from the federal perspective, the NDMS is the VA, the DOD, the HHS, they all get together, they do exercises, and at the end of the exercise, and they have their 500 patients, they say, and then the patients go to the hospitals. And it's that last piece of the organizing of the hospitals that is really the big gap that we're looking into right now. We're running out of time. I think this has been a very interesting discussion. If we could briefly touch on the funding issue. That was another question from the audience. David, can you take like 1 minute to talk about, so how do you fund this? You know, the hospitals aren't going to magically organize themselves. They're all competing with each other. How do we make this happen in the real world?
That's right. And HPP funding has been cut basically in half of the last couple of years. And so, you know, we have to really think about this. And really, when you look at the CMS emergency management chapters, Joint Commission chapters on emergency management, and you look at all the accrediting bodies for hospitals and healthcare facilities, it really, it equates to an unfunded mandate, right? It doesn't say you must have an emergency manager, but you ought to. It really is something that is necessary. So how could funding continue? Well, I think, you know, this needs to be a legislative priority first and foremost, and we're getting a lot of money associated with the COVID-19 response and the last two push-outs, but that's not sustainable, and that's not enough. And I would propose that CMS looks at this in terms of reimbursements and strategizing with healthcare insurance to either create a tax or create something where there's a stream of money that is continually that could be continually used for emergency management, in the sense that it is continuity of operations. You are trying to keep the doors open so you can still charge for patients, and that needs to be in the business model, and it needs to be looked at from a number of different points, from a national strategy as well as integration with disaster processes. You're never going to do emergency operations well if you don't do operations well. So it really has to start, at the groundswell level, at interaction with every patient.
My sense, I agree with most of what David said. I mean, being from Texas, I don't know that the tax thing would float here, but I do think it was, there ought to be incentivization for the healthcare systems. They do things like chest pain accreditation or other things because they're going to get additional patients, or they're going to get additional revenue from STEMI cases, or you see what I'm saying? I think the funding is disproportionately, it's been 2-to-1 FEP to HPP for years. It's been 2-to-1. And the other problem is the public health guys. I mean, I love my state health department partners, but they're first at the trough because they get both sets of money to them and then they're distributed, and they're already 2-to-1. And so it's been a little bit mismatched. And I think COVID-19 has shown us that hospitals and healthcare systems, acute care, are sort of important to the process here. And so I frankly don't know how many more labs we can buy versus the way we've ended up. I mean, we've spent a lot of money on things that I think the easiest way for me to get hospital interaction is when there is real money. They'll come to the meetings. They'll participate. And I hate to say it, but it's because there's going to be decisions to be made about how that funding is spent, and they're a part of that decision-making process. And then the other thing is we don't have as much fear over the last 10 years or so. After September 11th, we had 5 years of interaction because everybody was scared to death. And the further away we got away from September 11th, the less scared people got. And we'll have hurricane planning and such. But I mean, I think pandemic has been so long that I think it's almost like the marathon of marathons. So I don't even know how to describe it. It's like almost like daily operations at this point. We've built up the infrastructure where it's not necessarily a disaster. It's just the way life is right now.
I think the two key points here are the HPP/HCC program has considerable limitations in regard to actual coordination of hospital-based response, both for political reasons that Eric pointed out, but also for other operational reasons that Dan and David talked about. And these alternatives of Texas RACs and other systems that are out there are interesting and worth exploring. And two, it ain't cheap to do that. And in order to get these hospitals and health systems to participate, they not only have to be funded, but they have to be empowered. And so looking at alternative methods for funding, whether it's grant-based systems like they do in Texas, or whether it's through a CMS kind of kick to hospitals to do preparedness, whether that's to organize through health systems, big health systems, coordinate across the board, whatever it is. I think we're in an era now, based on COVID and based on these other potential big disasters and catastrophes, that we really have to start thinking about alternatives and start diving into how we're going to make sure that in a catastrophic event like COVID or a big earthquake in the New Madrid area, we can organize hospitals to equally distribute and load share these patients. So thank you all very much. We're out of time, and I appreciate all your participation. And thank you, audience, for the questions and the comments. Talk to you all later.